First of all, I would like to thank you for the opportunity of hosting me today to talk for the third year in a row. We'll be talking here about a new grading system for achalasia patients, which we developed in Benevento, the FBF Score, named after our institution, a multifactorial grading system useful for the detection and prognostic evaluation of achalasia using Barron's-Wallow. The score is obtained through guided image analysis and structured reporting and compatible and adherent to the manometric Chicago classification of achalasia, which is a clinical classification. It can be used in patients with a clinically suspected achalasia, manometrically diagnosed achalasia, or patients with dysphagia and suspected achalasia. We thought we'd introduce a new score because high resolution esophageal manometry is now considered the gold standard in the diagnosis of achalasia, but Barron's-Wallow is considered a dying art as well, relegated to a secondary supportive role. And we thought we had to revamp the Barron's-Wallow and the role of imaging in the diagnosis of achalasia, mainly because the only existing radiological classification for achalasia is Brombert's from 1980, so 41 years ago, in which the disease was interpreted as a single progressive process with four distinct consecutive stages based on morphological and dimensional criteria only, something which has been shown by manometry to be obsolete. Actually, achalasia is made up of three different entities, not just a single progressive progress. Type 1, 2, and 3 respectively hypertonic, pump pressurizing, and spastic achalasia. Each and every one of them has got impaired lower esophageal sphincter relaxation, but different manometric pressurizing patterns make these three entities three completely different diseases, which are differently susceptible to therapy. Type 2 is the best treatable, type 3 is the least treatable of the three. So the study started in June 2017 with a radiological profiling of the three Chicago subtypes. Then we collected 141 patients already diagnosed with achalasia and manometry, evaluated them using the protocol shown in the picture here, reviewed them in blind using two GI specialists, which then reported using our structured report attain FBF score. The data was then compared to assess FBF score accuracy in subtype prediction. Uh, for doing so, we developed a FBF checklist. So we could do radiological profiling with three Chicago subtypes. Five different imaging findings: Berbick sign, esophageal dilation, hypertonia, endoluminal stasis, and spasm have been thoroughly studied and defined, as you can see in this line here, for each and every one of them. So there's no margin of error in defining these five findings, which are the only five findings found in the three entities of achalasia. So we calculate an FBF score for each patient using this scoring system with 2 points for Berbick sign, luminal stasis, and hypertonia, -2 for spasm, and 2, 4, 6 points, keeping the Brombert's classification criteria for the esophageal dilation. Chicago subtypes 1, 2, and 3 were then individuated with an FBF score of 8, more than 8 for subtype 1, 6, 8 for subtype 2, and 0, 6 for subtype 3. Score 8 with hypertonia considered a type 1, score 6 with spasms is considered a type 3. Now let's look at the images. Type 1 here. As we can see, we have a Berbick sign, we have dilation of medium degree, endoluminal stasis, and hypotonia, which accounts for a FBF score of 12. So a type 1, Chicago classification type 1 matching for this patient. Type 2, the Berbick sign, dilation of 4 centimeters, endoluminal stasis 2 points each. Hypertonia and spasm not present, FBF score 6, matching the Chicago classification type 2. Type 3, Berbick sign is present, dilation is present, endoluminal stasis and hypertonia not present, spasm is actually present in this patient. So we have an FBF score of 4, type 3, matching Chicago classification type 3. Now let's look at the results. As we can see here in sensitivity in prediction stage, Type 1 was a 98.03 in sensitivity, so 50 out of 51 patients were correctly diagnosed. This is maybe due to the presence of at least 4 combined radiographic findings in subtype 1, except for spasm, of course. Type 2 and 3 have a sensitivity of more than 90%, which is really good data. Spasm showed high specificity in subtype 3, 95.65. Stasis showed high sensitivity for subtype 2 with 93.18. So what we can see in conclusion is radiographic grading of achalasia using FBF score is shown to be highly sensible and accurate when compared to the manometry results, especially in subtypes 1 and 2. FBF score implementation might allow for more precise morphodynamical analysis, structure reporting, and better overall diagnostic support to manometry. It's actually a guided process. You cannot make errors, and especially it's good for patient stratification and therapeutic choices. But this study is monocentric, patient number is limited, so further larger studies are actually needed to fully validate the FBF score. So thank you.